Thank you, Mr. Sherman, for the introduction. Thank you for the organizing committee for inviting me. Every day, we deal with our patients, trying to provide to them the best possible care. And regarding AAA patients, we have to choose between
voice, please.
we have to choose between open repair and EVAR, with these different variables and different varieties of EVARs. However, there is a group of patients that are turned down for surgery for one reason or another. And once the decision is taken, we let them go. We don't know much about them afterwards. We don't know what happened to them. The turned down patients rate is about 88 to 31%, according to different meta-analysis done. And we're all familiar with this study, the long-term outcome of EVAR, which have showed that the EVAR loses its long-term benefits compared to the open repair, the survival. That was again showed in the DREAM trial and other studies. However, there is this has been also in other multiple randomized controlled trials and other studies, but always this group of patients is missing in reporting. Perhaps EVAR2 is the only trial that have mentioned that has included these patients and have concluded that although the EVAR benefit in the benefit of the reduction of aneurysm-related mortality, but it did not reduce the overall mortality. That's why we're interested in this particular patient group, what happens to them, when they die, how they die, what is really the rupture risk, rupture possibilities, and more importantly, are we doing the right thing with turning it down? So we have looked into our database, retrospective prospective database. So we had 11 years period from January 2006 to December 16, and we have looked into our patients, patients that were turned down. We followed them afterwards with information from the National Death Registry about the mortality, when, how, what are the causes of mortality. We found that we had 457 patients. About 45% of them had an open repair. EVAR had about 38.3%, and 73 patients were deemed unfit for elective repair. In addition, there were another 3 patients that were not were offered surgery but refused surgery. So this included a total of 76 patients of 16.63% of patients that were managed conservatively, with an age about 80 years. You can see here this table, the cardiovascular risk factors, as you would expect, quite high. But more importantly, here the number of malignant patients is quite high as well. About 40% of patients had an active malignancy, aggressive malignancy at the time of presentation. The mean size of the aneurysm at time of discovery was 60 millimeter. This is a ASA grading. Only 13% of those patients were suitable for EVAR. The patients, the way we assess the patient, just briefly, that we assess them in MDT meeting, decide if they're suitable for EVAR or open. Then they are assessed by anesthetist, who would run the required preoperative tests. Afterwards, they are if they are unfit, they are back to the MDT discussion. The final discussion is taken between the patient and the consultant surgeon at the outpatients. Then we try to provide what would happen in the scenario of presentation as rupture. So that's why the follow-up is not afterwards not uniform. It's not uniform. Some patients will never be back to outpatients afterwards. But we found that we would collected the data from January 17 up to April 17, about 49 patients were recorded as dead. for those patients, we found that the aneurysm-related mortality was about 30.6%. And interestingly, malignancy here caused mortality in about 32.65%. As you can see here, most of those patients die in acute hospitals, about 49%, or other places, hospitals or nursing homes. We recorded 16 patients who presented with a ruptured aneurysm. Only one patient who had an open repair at this time of the acute presentation has survived. And interestingly, this single patient was actually one of those 3 patients who were previously were offered surgery, but because they were fed, but they refused. And all other 5 patients who were operated on has passed away shortly after surgery in the period. Other patients were in palliative or just were found in autopsy. Plotting the risk factors, age, as kind of to try to see if they would behave any difference. If they are younger or older than 75, there was no difference. Also, we tried to figure out what's less than 70, 75, or more than 75, there was no statistical difference. However, interestingly, the malignant patients, as you can see here, as recorded cause of death, about 70% patient passed away from the malignancy rather than rupture. Only 2 patients had the rupture, was a statistically significant finding. And this is the last Kaplan-Meier curve, plotting our EVAR versus open versus the conservative managed group, and we can see that the conservative managed group behaved much worse than the others. And again, we showed the similar trend of the EVAR would lose its benefit shortly afterwards. So to conclude,
Dear doctor, your time is up.
so majority of those patients would die from causes unrelated to their aneurysm, although some argue that about 30% would die from the aneurysm rupture. Attempting repair on such patients does not add any benefit to such terminal patients and should really manage palliatively once they are deemed unfit for elective repair beforehand. And survival is not related to their age at the time of the turn down. But patients with active malignancy should definitely not be offered, with active malignancy that are likely to die from it, should not be offered surgery electively. And then I'll leave you with this last quotation phrase. Thank you very much.